Yeah, I'm Kyle Mobley. Will gave my kind of background. I'm currently in Tallahassee, Florida. The title of this talk, Orthopedic Multi-Tool. That's basically how I see IlluminOss. You'll see that we use it in quite a few different instances and just like to have it as a tool in our tool belt. So game plan tonight, we'll cover first a fragility fracture in the acetabular region. We'll have, after that, a fracture in a pre-existing deformity, and then a proximal humerus fragility fracture, which is probably my favorite indication for IlluminOss. Starting off, here's a 66-year-old patient. You can see he's had a prior hip fracture. He had another fall. The patient has a history of 2 strokes on the left side. So he's got essentially non-functional left upper extremity, and he uses a hemi walker because his left lower extremity is also weak. Here he's got a left acetabular fracture with a little bit of protrusio. You can see he's kind of protruding into his anterior column. Got a CT scan on the next slide, where you'll see this is a pretty typical geriatric fracture pattern. Somewhat displaced. He's got involvement of both anterior and posterior columns. So this guy, given his comorbidities and his weakness on that side, we initially treated him non-operatively, but he was unable to tolerate that. Over the course of 2 days, he was unable to tolerate even mobilizing in bed to change position. So therefore, we started talking about surgical options, and we talked to him about this IlluminOss option, and he thought that sounded great. This is the kind of fracture that led me to search out IlluminOss, and specifically being able to exploit this corridor here. So this is an approach, approach to the posterior column, and instead of using your standard corridor, I'm starting here at the gluteus medius pillar and going down the pillar, and then using the confluence of corridors just above the acetabulum to snake around posteriorly into the posterior column. So here's my start point on Jade views, and if we'll go to we'll have a series of slides just running through snaking down that posterior column. So once I got my start point and opened it up with the entry reamer, I had a bent ball tip guide wire. So I came straight down toward the acetabulum and then started snaking it around posteriorly. And then with the benefit of your standard views, I was able to snake it all the way down to the bottom of the ischium. And then he had involvement of the anterior column too. So we did kind of a standard approach to a retrograde ramus screw. There's a start point. And then obviously with a curved implant, you're able to get more than just your straight corridor. So I curved that around to get even more posterior there. Obviously ream over that, ream up to an 8mm reamer, and then input your balloons and inflate those. And that's what we ended up with. These are 2-week post-op. You can see he hadn't displaced. The day after surgery, he was actually up with physical therapy on his hemi walker. We had ostensibly made him touchdown weight bearing, but for all practical purposes, he was weight bearing as tolerated, and asked to leave the hospital the next day. Her caregiver is her mother, who's very involved. She doesn't know exactly how this happened. The leading theory is she's got severe adduction contractures with her hip dislocation, and just spreading her legs to just perform hygiene. Obviously, you can see she's had multiple fractures in the past, treated surgically, and then probably one that they didn't know about treated non-surgically at some point, given the degree of deformity in her femur. She was in pretty severe pain. She wasn't able to communicate with words, but you could tell just by being in the room with her, with hearing her scream and moan, that she was in a lot of pain. Mom was pretty insistent on surgery. I felt we kind of had a couple options. One was a plate that I would contour in 3 different planes, but we had also had this new implant called IlluminOss. So I talked to the mom about this, and so we've got some fluoro shots coming up. So here's same strategy, bent ball tip guide wire, advance that across the fracture, put this in just like any retrograde nail as far as start point and trajectory. Get the implant across after reaming up and then inflate. And then just specifically because of the torsional deformity she's got going on, I really wanted to put in interlocks. These are just 4-0 interlocks from a nail. And then here's a 2-week post-op, and then we followed her out. I'm still seeing her, but this I think is 6-month post-op. Doing really well. She was a lot more comfortable in the couple of days following surgery, and obviously had a good result. And then I mentioned at the beginning that probably my favorite indication for IlluminOss is proximal humerus. This isn't a wildly displaced proximal humerus, but this is a pretty typical situation that I see. Is now this lady actually had an intertroch also, so we fixed the intertroch on her first day in the hospital and told her we typically manage these non-operatively. Over the course of the next 2 days, she just told us she couldn't tolerate non-operative management. She felt like her fracture was moving all around and she had too much pain, so she requested surgical intervention. This patient had a history of chronic kidney disease, diabetes, a gastric bypass, and a revision gastric bypass. So, and she was 64 years old. So instead of talking about open reduction, internal fixation, we discussed closed reduction and placement of an IlluminOss. You can see she's got about 50 to 70% displacement and a lot of extension there on the lateral, even though the AP looks pretty good. So then we get her into the operating room, perform a closed reduction. You can see we got rid of her extension and the translation. We put this IlluminOss in just through a 1-inch incision like you would make for your start point for an intramedullary nail. Hold this reduction while the polymer hardens, and then immediately intra-op, we have a video here just showing the stability intra-op, the whole thing moving as a unit. She also felt significantly better the next day, and this is a 2-week post-op. She was supposed to follow up today and didn't show up for her visit, so you can take that either as a good sign or a bad sign, as you will.
Okay, great. Thank you, Dr. Mobley.